That's right.
All right, so today this was put together by Judy Greenberg and Adam Greenberg. Yeah, how sweet, huh? I'll even throw my name in the hat for, you probably, no, where is he? I was trying to see, I thought I saw one of the other guys from my previous system probably saw this in 2015 because they used a lot of my slides from 2015, so. We are no longer calling strokes, CVAs, we're calling them brain attacks now. Well, we got to keep things fresh, you know. But bottom line is, it's a disruption of blood flow to the brain. We know that the brain needs oxygen and needs glucose, and any drop in any of that, the brain is going to start to go ahead and not function like it was supposed to. So we look at a couple different types of strokes. We look at ischemic stroke and hemorrhagic stroke. We also have something called TIAs, which some of you could describe as mini strokes that usually resolve themselves in a certain amount. Now, some of the ischemic strokes that a patient has, based on the amount of anaerobic metabolism that the body has and the destruction of cells, just to kind of keep it on that kindergarten level. But bottom line is that we can end up sometimes having cerebral edema, which kind of makes it into like the hemorrhagic conversion, or kind of signs and symptoms of a hemorrhagic stroke. A lot of stroke statistics here. Bottom line, strokes are bad. People have strokes once every 40 seconds. And the big thing about, I think that's most important for you guys to know, is that strokes are debilitating. I know you guys have probably heard me talk about this before, but I have a very close friend who was a Waukegan firefighter, and he ended up having a stroke. He was underneath one of the fire trucks fixing something, and someone thought it'd be funny to turn on the siren, and he turned his head really quick. Well, he had plaque built up in his carotid arteries, and when he turned his head real quick, some of that plaque broke loose. And it went to his cerebellum, had stroke, really almost lost his life at that point. But he was at the time very active. He went fishing, he did camping, did traveling all over the place, loved to fix things, and now he's, aged probably about 35 years at that point. He walks with a walker, or a cane. He has problems swallowing. He has very short-term memory loss. Sometimes some long-term memory loss, and he does suffer from depression. Obviously, he lost his career, no longer could be a firefighter, paramedic, and so this was very hard on him. And strokes, it's just not firefighters and paramedics that suffer from this, it's anybody that ends up having a stroke. It can be very debilitating and psychologically can, almost destroy some people. And you can see by this chart, and it does say people over 65, but it really doesn't matter the age. People suffer from these types of things regardless of whatever their age is. We can do things to control whether we have a stroke, and there's some things we can't do. Age, gender, our ethnic race based on our, 23andMe, you're kind of out of trouble based on your ethnic. Gotta pick on you a little bit. Those things we can't control, but are we going to control what we do as far as blood pressure? Sorry, I thought I shut this off. Our blood pressure. How active are we? What do we eat? What do we drink? Do we do drugs? Are we obese? Those are things that we can work on to go ahead and decrease our likelihood of having a stroke. All right. So here's some different types of strokes. TIAs. TIAs, trans-ischemic strokes, really mimic an ischemic stroke. We don't know pre-hospital if someone is having a TIA or if they're having a stroke, because TIAs will resolve themselves within or up to 24 hours. We treat them just like we always would. Most people that suffer from a TIA will sooner or later have that big stroke. So we need to go ahead and take those pretty seriously. Yeah, you're still going to call a stroke alert If someone has a history of TIAs, you're going to call the stroke alert. We'll let the hospital go ahead and make the determination if it truly is a TIA versus a stroke. Now, what are some signs and symptoms of an ischemic stroke? Let's start with those. Remember, an ischemic stroke is a stroke that has a disruption in blood flow due to either an emboli or a clot. One could be the fact that someone has AFib, and in that left atrium, a clot builds, and that clot ends up getting discharged from it, ends up going to the brain. It stops up one of the vessels in the brain, blood flow doesn't go to it. You can also have another type of stroke, which, talking about the carotid arteries, for example, that plaque breaks loose. When that plaque gets damaged, the body thinks it has to go ahead and fix this. So it sends all sorts of fibrin to go ahead and fix that, that injury. Plus, platelets will go ahead and go over it, they get stuck, and it makes the vessel smaller and smaller until it finally actually occludes that vessel and doesn't allow blood flow downstream. So there's a couple different types that we worry about. Up here, you know, it talks about 4 different types. We really focus on the emboli type and the thrombus type strokes. Most of the patients that we deal with are going to have an ischemic stroke, and 13% are going to be hemorrhagic. Just a piece of information, I find it kind of fascinating. Over in China, it's completely the opposite. Majority of the strokes are hemorrhagic and very few are ischemic. They don't know why. They're doing lots of studies to try and figure it out, but it's just kind of interesting on the other side of the world, you know, completely opposite of what we see here. So as far as ischemic strokes are concerned, slurred speech, facial droop, unequal grips or deficits on one side. That's what we see for signs and symptoms. We can also see garbled speech depending on which hemisphere the stroke is actually dealing with. People who have AFib are more likely to go ahead and have a stroke. History is going to be important. When you guys have these patients and you go through and try and figure out what medications are on and what their history is, if you see someone who does have some of these signs and symptoms and they have AFib, it's probably likely. One of the Cincinnati stroke scales, whether it's speech, arms, or face, 73% chance that a person is actually having a stroke. So this is our protocol for our rapid AFib aflutter. You have a patient who is a 72-year-old male patient. Today is experiencing some lightheadedness, weakness, some dizziness. Blood pressure is 110/70 and heart rate is 88. And you put them on the monitor and they are in AFib. Do we use this protocol on that patient? What do you think? Why not?
Stable.
Well, they're stable, but this says stable BP greater than 90, patient's alert, skin's warm and dry. Are we going to give someone who is in AFib and a rate of 88 verapamil? No. This is more on the lines for uncontrolled AFib. Maybe someone who has a heart rate greater than 120. Also remember, you could have AFib with RVR, the rapid ventricular response, and these patients may have rates up greater than 150. And it's hard to recognize if a patient actually has AFib, SVT, AV nodal reentries. You know, there's a whole lot of different types of rhythms under that SVT umbrella. So yeah, this one here we would only go ahead and use for someone who's has the uncontrolled AFib. We start off with our Valsalva maneuvers. More than likely, they're probably not going to work. And then we give verapamil. You'll probably see the dosage later on. It's 5 milligrams IV push over 2 minutes. And if our patient still isn't doing well after 15 minutes, I know you guys are well gone from the hospital by that time, we can go ahead and give another dose if we're still transporting these patients. Now in the unstable patient, it talks about someone who has altered mental status, BP less than 90. with all the other signs and symptoms, maybe some chest pain, dizziness, weakness, history of AFib, rapid heart rate. With these patients, we're going to go ahead and cardiovert them. But one thing that we always try and stress here is that, please, we just don't want to cardiovert everybody. Is it a new onset? What kind of medications are they on? This is probably a good time if you're really unfamiliar with cardioverting someone AFib. Talk to medical control, ask them. We start off at 100 joules or the biphasic equivalent, 200, 300, and then 360. We do give the 2 milligrams of Versed up to a max of 10 based on sedation for our patient. And don't forget, we can also give them fentanyl for pain management if need be. Anybody have any questions on our AFib protocol? All right. So verapamil, calcium channel blocker. We use it for patients who are SVT that do not respond to the adenosine, and we also use it for our patients who are rapid atrial AFib or aflutter. Be very careful. You don't want to slam it in. You're going to push it in over 2 minutes. If you slam it in, obviously it can cause hypotension in our patients, or it can cause bradycardia. Yeah, you're trying to slow the heart rate down a little bit, but not drop them down so much. Don't use it for patients who are in those higher degree blocks, like 2nd and 3rd degree, or they're hypotensive already, or have CHF. With our hemorrhagic shock, hemorrhagic stroke, signs and symptoms can be a little bit different here. These patients may complain of the world's worst headache, someone who has some blurred vision, double vision, vomiting, projectile vomiting. You might see all of that with these patients. This is where we actually have one of the vessels within the brain actually ruptures. And if it gets bad enough, we can go back to seeing the increased ICP. We'll see the Cushing's triad, high blood pressure, low heart rate, erratic respirations. Okay. Now there is 2 different types of hemorrhagic stroke. For you guys, it really doesn't matter. They've got a brain bleed. But you can have the intraparenchymal, which is deep down in the brain itself. One of the blood vessels bursts and leaks blood into the brain. Or the subarachnoid hemorrhage, where one of those vessels near the surface of the brain actually will rupture, and it does cause a shift too in the brain. Most of our hemorrhagic strokes are going to be the intraparenchymal. Very few are the subarachnoid. Most of these are going to have a sudden onset as far as what we see. So when we take a look here, you guys bring in a patient with a stroke. Calling that stroke alert, first of all, is very important because it helps us clear that CT scanner. What they're going to do is they're going to run a CT with non-contrast to start off with to see, is there a bleed or is there not a bleed? So if we take a look at a normal CT, you don't see any of this white here, which indicates that there is bleeding. Here's just a graph. We've got the blockage here, and this area is the area that's not getting the oxygen and the glucose it needs. Here, the bleed is, it's bleeding out right there, and it's putting pressure on the brain and kind of shifting things a little bit. So those are the 2 different types, and that's what they're really looking at with our stroke. Again, we have some more, intraparenchymal versus the subarachnoid. Normal CT, but here it's deep down within the brain. And over here, we've got the subarachnoid bleed up near the surface of the brain. Now, when we take a look at where is the injury, you guys have been told that if a patient has an ischemic stroke, if we can get them TPA within, 3 to 4.5 hours, they might gain some of their neurological function back. This area right here, or the zone of ischemia, that area is not coming back. Where we're actually looking to try and fix is the penumbra area for these patients. This is going to be necrotic. Nothing we can do. But the penumbra area, that actually can be viable for quite a few hours after the injury has actually started to occur. And there's new procedures out there that we can do if a patient doesn't qualify for TPA. So here's our hypertensive emergency protocol. When we look at our hypertensive, we're looking at blood pressures greater than 220 for systolic or diastolic greater than 120. It doesn't have to be both. You know, some people say, well, it's, you know, 240 over 110. Nope, it's not a hypertensive. It can be one or the other. Look for other signs and symptoms of neurological deficit. Look for, do they have a headache? Do they have a nosebleed? Those are the types of things we want to let medical control know. Is there seizure activity? Now, as far as our treatment for hypertensive crisis, we can do our routine medical care, take a blood pressure on both arms, and that's pretty much it. Giving a patient nitro, you have to make sure you have a really good history on these patients. Make sure that you're getting medications. Make sure you're getting their health history. Look at all the signs and symptoms that you can see right there and try and figure out, are they having a stroke or are they just having a hypertensive crisis? Because medical control is going to want all that information before they allow you to give nitro to these patients. Remember, nitro can cause vasodilation and sometimes make that bleed worse if it ends up being a hemorrhagic stroke. So nitro we use for a couple different things. We use it mainly for chest pain or, for chest pain. It can be used in our CHF protocol. It can be used in our hypertensive protocol. We don't give it to patients who have blood pressures less than 90 systolic, those that are on ED medications, someone who might have a cerebral hemorrhage or head trauma. Some of the side effects, when you give the patient nitro, does it get that burning sensation underneath the tongue? Do they get a headache? Does their blood pressure drop a little bit? Maybe some nausea and vomiting associated with it or dizziness. Pediatric strokes, peds, it's not uncommon for peds to have a stroke. I think, who was it? Nick, who was talking yesterday? Was it you guys? You were talking about the 20-year-old that had the stroke?
Yeah.
Was that here?
Yeah, it was me, Wojo, and it was John. Yeah, it was 22.
Yeah, it's not uncommon to see a 20-year-old or even less than that have a stroke, but it's sometimes difficult to recognize it because you're sitting here thinking, oh, a 20-year-old's not going to have a stroke, or a 6-year-old is not going to have a stroke. Making sure, again, you're doing good full assessments on these patients. The signs and symptoms are going to be very similar to that of an adult. You know, ischemic stroke, they're going to have the deficits, maybe speech, facial droop, one-sided weakness. Why do these kids have stroke? Well, there's a lot of different things. Congenital issues that we may not know about yet. They might have some type of infection is another big one. AV malformations, if it's a hemorrhagic. Sometimes they have sickle cell, and sickle cells kind of bunch up in one area for them. Our treatments for our pediatric patients are the same as what we would treat in an adult and how we would care for them. One thing about children, though, is children usually do a lot better than what adults do. They're younger. Their bodies are actually in better shape. Their brains are still growing, okay? But we see that, you know, the kids do a little bit better. So, some of the things that you might see in addition to the same signs and symptoms as adult. In newborns, you might see seizures occur. Worsening headache. Headaches that they can't explain. They don't have a history of migraines. I think last year in the stroke lecture, I actually showed you guys a video of a newscaster. She was on air, she was talking about the Grammys, and all of a sudden, her mouth, or her words started to really garble up. And everybody's like, oh my gosh, she's having a stroke. And that's exactly the way the paramedics treated her. But it turned out she just had a cluster migraine. And that's something that is one of those mimickers that we see, or those differential diagnoses. They might have difficulty speaking, slurring their words, or even remembering. This is a, and trying to figure out that it's a mug. They might have loss of balance or trouble walking. Eye problems, vision disturbances, light sensitivity. So, we do not have a pediatric SOP. We just follow our regular adult SOP for that. There really is no differentiation between the two. Don't forget though, don't just get that tunnel vision and say, oh, they're automatically having a stroke. You got to try and figure out, Are they really having a stroke or are they not having a stroke? You know, hypoglycemia, epilepsy is a big one. Do they have a migraine? Do they have a head bleed, head trauma of some type? Do they have Bell's palsy? Bell's palsy is always a good mimicker. That's, remember, the infection of the 7th cranial nerve. And one way you can determine if someone is having a stroke versus Bell's palsy is ask them to wrinkle up their forehead or raise their eyebrows. Bell's palsy, they won't be able to do that. With a stroke, they can do that. Are they on drugs or alcohol? That could indicate. So once you start ruling all of that out, you can kind of get down to really what's going on with your patient. This slide is pretty interesting, but if someone has a stroke, it can add up to 36 years onto their life as far as their age is concerned. You know, per second, 8.7 hours. So it's pretty interesting. Some of the other common stroke signs and symptoms, if it's a right hemispheric type stroke, slurred speech, they might have left hemiparesis. Remember, things usually switch sides or cross sides. You might see someone who has that right hemispheric stroke, their eyes deviate. If you have them open up their mouth and say ah, you might actually see the uvula go ahead and deviate to one side. On the left hemispheric stroke, the speech is a little bit different. It's more of a problem trying to figure out what word is associated with what object. They can't get the words out. They might have a hard time comprehending what you're saying or trying to comprehend what's going on, and again, trying to get the information across to you. They might have that left gaze preference. If it's a brainstem type stroke, nausea, vomiting, headache, world's worst headache that they might have, abnormal eye movement, that nystagmus might come in, problems swallowing, even speech problems. And sometimes these patients have altered mental status as far as decreased level of consciousness. So what are we going to do? Well, you're going to call for someone having a stroke. Very important is our ABCs, maintaining the airway. We only give oxygen for these patients if they are hypoxemic. We don't give oxygen any other way. As a matter of fact, American Heart lowered their oxygen down to 92% versus what we still keep it at 94. When we redid the protocols, they wanted to keep everything constant for this. They didn't want to confuse you guys anymore, whether it's 94 or 92. So run a 12 lead, but don't delay transport for that 12 lead. Yeah, it's nice to get a 12 lead, but if you don't have time, then don't. Do we start an IV on these patients? What do you think? We can if we have time and we know we're a good shot and the patient has great veins, but for the most part, our treatments are not going to require that IV. If you know this patient's a difficult stick, if you know that they're hard to go ahead and get an IV on, let the hospital go ahead and do it. Make sure you're checking a blood glucose. I actually had, quite a few years ago, one of my biggest mistakes for a patient. I live up in Burlington, Wisconsin, and we have a little doc-in-the-box hospital in our town. It's not a bad hospital, but it's still nothing, no stroke, no cardiac. And we actually had a guy who was a stroke, got tunnel vision very early on in my career, and thought, oh, I'm going to fly this guy, because back then, you know, calling a helicopter was cool. And so we flew this guy up, and a couple days later got a call from my medical director, had to meet with him. I forgot to check a blood glucose. Guy had a blood glucose at 28, ended up with, back then, quite a huge helicopter bill. I ended up on probation for a little bit because I didn't check the blood glucose. You know, mistakes like that happen when you get tunnel vision. And you know, now I know I never ever make that mistake again, but it does happen, but we need to check that blood glucose. Fix something that would have been very easy to be fixed for him. So, if you have someone too, and how you position them, if they're having difficulty swallowing, go ahead and put their head up, 45-degree angle if you can, just so that they don't aspirate. If they're unresponsive, you can turn them to the left side a little bit so that, you know, they don't. Get them intubated if necessary. And protect the side of the weakness. You know, these little van ambulances that they have, you know, one of the arm drops down because of the fact the patient can't hold it up. They might get it caught, and they're not going to know because they don't feel something, or it's, you know, just has some numbness or tingling. You know, make sure you're keeping the left or whatever side it is protected. Do a good exam, your sample, your OPQRST. Find out, when was that patient last seen normal? When did symptoms start? Well, I went to bed about 10 o'clock last night, and this morning when I got up to go to the bathroom, I noticed that I had a problem moving my right side. Well, did the symptoms start just before or just after they went to sleep, or just before they got up? We don't know. But that's important information to know, so whether or not it depends, it'll help us make the determination of what treatments the patient may end up having. What other things are they complaining about? Do they have a headache? Is there sudden confusion in these patients? Dizziness, weakness, stiff neck? Are they sensitive to light? Are they having seizures, trouble speaking? Make sure you're noting all of that and giving that information to the hospital. What is their GCS? So, do you guys perform the cranial nerve tests on your patients? Yeah, actually you do. Well, a lot of people, we say, I don't do that, but you do that without even knowing it. You know, you look at the pupils. Are they responsive? Are they equal? Have the patient follow your finger. Are the eyes moving like they should and together? Even going ahead and listening to the way they speak. Having them say ah, sticking out their tongue, lifting up their arms. There's so many different things as far as in cranial nerve assessment you guys do without even realizing it. But make sure you're doing, you know, checking those pupils. Having them follow your finger. Do the eyes move together? Stick out the tongue. Is it abnormal? Does it deviate? Does your uvula deviate? Now, we use a pre-hospital, Cincinnati pre-hospital stroke scale, and that's the facial droop, arm drift, and slurred speech. We have them say sentences like, don't teach an old dog new tricks. And I know that's one of the sentences because it's based off of different syllables and words that they use, but really you can determine if someone has slurred speech. If you're not sure, if there's family there, say, is this normal for them? Are they normally talking like this? Does their face normally look like it's, you know, drooping? So for our stroke protocol here, we're going to do our routine medical care. Start off with getting a glucose of these patients. We want to do this right away because if it is glucose, they're hypoglycemic, we can fix that fairly quickly. If it's less than 60, give our dextrose or our glucagon, and then do our stroke scale. When you document your stroke scale, make sure you're documenting arms, you know, no deficits, facial droop, no facial droop, and you can say too, speech, no slurred speech. Don't just say stroke scale is negative, because what does that really mean? We also need to know if it does have some type of issue, which one is the one that has an issue. And like I said, 73% chance if one of these is abnormal that the patient is actually having a stroke. The other thing we look for is there any neurological deficits? You know, do they have altered mental status? Do they have unequal pupils? Do they have a really bad headache? Are they posturing? If they are, then we're going to go ahead and we want to start ventilating these patients. We can start with the bag valve mask, and we can ventilate one breath every, one breath every 3 to 6 seconds. I was going to say 3 to 5. Or 20 times a minute. It's not a bad idea to go ahead and get these patients intubated. Use your drug-assisted intubation if you need to. But we want to ventilate them enough to go ahead and keep the end tidal at about 35 for them. Remember, oxygen causes vasodilation. CO2 causes vasoconstriction. We don't want to go, oxygen causes vasoconstriction, CO2 causes vasodilation. Got that mixed up. We don't want to go ahead and constrict those blood vessels so much that we decrease perfusion pressures within the brain. Okay? So breathe for them, 20 times a minute. Go ahead and keep the end tidal at about 35, or that lower end. American Heart is doing a lot of community education. There's commercials out there, all the different types of open houses. They always have some type of information, but the pre-notification to the hospitals is very important. For you guys to go ahead and determine that a patient is having a stroke, letting the hospital know. The hospital, or at the hospital, if we're talking about the time frames to be part of a stroke center, that they have to be at CT or in CT within 25 minutes of you guys coming to the hospital at the doors. That CT must be read within 45 minutes. And then if that patient is a candidate for TPA, then that medication needs to be on board within an hour. Those are the time frames that they're actually looking. Now, at Evanston, I know at St. Francis you're not doing it, but at Evanston, do you guys go take the patient straight to CT if you have a stroke patient? No? I know there are some hospitals out there that they're doing that. If you call a stroke alert, the doctor will meet you right as you walk in the door. He'll do a quick assessment, and then they go right to CT with them. Which is good because it takes a lot of time off that hour clock for them. Gets them down there a little bit sooner. We are a primary stroke center at St. Francis. You can see by the top picture all the different primary stroke centers.
EMS 5 ambulance 22, engine 22, fixable, South Boulevard, going in Eva Edward for the 85-year-old female, high blood pressure, elevated heart rate. EMS 5 ambulance 22, engine 22, 612, South Boulevard, townhouse E, Edward.
Settle down now.
Okay, the difference between the primary stroke centers and the comprehensive, it depends on what kind of interventions. A lot of times the comprehensive will have interventional radiologists. They can do some other types of interventions, such as coiling or breaking the clot up and vacuuming it out, if you will. Primary stroke centers can go ahead and at least start some of the treatment, maybe TPA if it's necessary. And most of them will transfer them to a higher level or to a comprehensive stroke center based on the needs of the patient. In our area, on this side, it lists all the different primary stroke centers. And the ones are Region 10 here. You can see, except for Swedish, isn't Region 10, Community First, or Illinois Masat. But all the rest of them are Region 10 hospitals. Currently, right now, the law states that you must take a patient that's having a stroke to the closest stroke center, or the primary stroke center. That means that if you are down near Community First, you drive by Community First to take them to a primary stroke center, or comprehensive. And then you can see over here the different comprehensive stroke centers. We actually, now that Resurrection is comprehensive, we go ahead and refer to them a lot. It used to be that, I know Rush is doing a real big research project right now, and there's a lot of hospitals that have partnered with them, and doctor comes online and is up on a screen. They boot up a computer, and the doctor in the room and then the doctor on the online will go ahead and assess the patient and make the determination what's best for them for care. So currently there is nothing out there. I do know they're working on it, but nothing as far as the law to go ahead and say you have to transport to a comprehensive stroke center. So when you guys are documenting, it's really important for you guys, like I said before, to document separately the Cincinnati Stroke Scale. Make sure you document the blood glucose, and then when did they last seem, when were they last seen normal? When did signs and symptoms start, if you can? That's going to be important because it's going to make the determination if they can have certain treatments or not. All right, so I'm going to show you just here 2 videos. This one here, you can see the clot there. They're going to go ahead and put a catheter sheath in place. They're going to use a separator to break up this clot. They'll put on an aspiration balloon at the bottom. And they're basically going to suck this clot out as they break it up.
I've seen this before. There. Uh-oh. Going to deep. Is this real?
It's a 5.
Oh.
Okay.
God.
And then they'll go ahead and retract their catheters here. And then that opens up blood flow. Okay. And this one is the coiling. Dr. Ahuja up at St. Luke's was very instrumental in the development of this procedure here. They will actually, there's a wire in there, a guide wire, that's actually going to coil around this clot, and they'll actually pull this clot right out.
My goodness. All right, pull it out. Come on.
Well, and that away it goes.
Oh.
Both of these procedures here can be performed up to 12 hours after the signs and symptoms start for these patients. So now, depending on too with these procedures, depends on, a lot of times they go into the femoral artery. They've actually, well, it's all physician preference. They've actually started going into the radial artery. You have it in the femoral artery, you have to lie completely flat, not even lifting your head up. They put a sandbag over your groin as a way to go ahead and, you know, stop the bleeding and have that kind of clot up there. The radial, the wrist is a lot better as far as getting out of the hospital sooner, okay, recoup. TPA is another way that they can go ahead. It's kind of like liquid Drano for the vascular system. It can be used up to 4.5 hours after signs and symptoms start. If it is an ischemic type stroke, they will go ahead. But if you take a look here, there's very few people that actually qualify for TPA. There's a lot of different variances, like have you been in an accident within a certain amount of time? What kind of health history? What's your blood pressure currently? You know, do they need to lower the blood pressure before they start this? Has someone been to the dentist? Have they had CPR, previous strokes? There's a whole health history that they will have to go through and ask before they administer TPA. And they, you know, they take and they weigh the benefits and the risks. What they're trying to go ahead and hope to do is to gain some of the neurological function that a patient may have lost for these patients. So hemorrhagic stroke, well, there's things that they can do, but I mean, they need that comprehensive stroke center. They have to find the source of the bleed. They may put some clips on there to go ahead, surgical clips. They may just go in and remove the clot and evacuate the blood that may be there. Sometimes there's nothing they can do for them. Now, as far as other community education, FAST is the new terminology that they're used. Facial drooping, arm drift, speech, and then they're talking about time. So if these people in the community recognize what time did the signs and symptoms actually start for them. The new information that's coming out, well, and here's the thing by both of them. Region 10 has not switched to the BFAST yet, even though that's what American Heart is currently using. I guess we have to vote on it from what I understand. But this is the new terminology, BFAST. One, take a look at their balance, you know, their movements. What are their eyes doing? Do they have blurred vision, double vision, light sensitivity, unequal pupils? And then we go to the FAST portion, the face, the arms, the speech, and then again to the time. But this is the new information that is being put out there to go ahead and the general public to have them call for you guys. All right, anybody have any questions on strokes? All right, moving on to the seizures here. We have some of our patients, only about 4% of our calls here within Region 10 are seizure calls or actual seizure calls. Yeah, most of the times, by the time you get there, these patients aren't actually seizing anymore unless they're suffering from status epilepticus, which are prolonged seizures. Now, there's two definitions out there that are seizures depending on what reference you read. One says that it's just a continuous seizure, it doesn't ever stop. The other one is that they never ever fully regain or come back up to baseline. You know, they kind of stay in that post-ictal state and then they go into another seizure. So it just depends on what reference material. We can break our seizures down into generalized or partial. Most of the time you guys see the tonic-clonic type seizures, the jerking around. Absent seizures are a little bit different. Those seizures are kind of hard to detect because all of a sudden the patient just starts staring off into space. Those are usually diagnosed a little bit later in life, not until late teens, early 20s. With your partial seizures, your simple partial seizures may be one extremity, arm, leg, part of the body that has a jerking type motion. They might be smacking their lips or chomping their, their mouth as a way, or really rapid blinking. Partial complex seizures, these patients usually have severe altered mental status and are usually unconscious. And then we have febrile seizures. We'll talk to you in just a minute about those. So status epilepticus, like I said, getting those patients back to their baseline. These are the true medical emergencies when it comes to seizures. We do see a risk of chance of death, and a lot of it has to do with hypoxia for them. Yeah, okay. Seizure mimickers, other things can cause it. You might see someone who just has abnormal movement, someone who has Parkinson's, someone who has Tourette's. Those are some of the seizure mimickers. Some of the other causes can be the fact that they have hypoglycemia, syncope, or cardiac arrest. So when we look at a patient with seizures, we want to make sure we're checking their sugars. Did the hypoglycemia cause the seizure, or did the seizure cause the hypoglycemia? Make sure we're checking them and treating appropriately. Someone who has a fever, mostly it's kids that we see and we deal with this, and it's not how high the temperature actually goes, it's how fast the body temp gets to that temperature. We've seen kids with 101 fevers end up with seizures. We want to make sure with these kids, if they do have the febrile seizures, that we're treating them appropriately. We're cooling them down, removing their clothing. We don't want to dunk them in ice water, okay? We don't want to use alcohol as a means of evaporation. But removing the clothes, taking off a tepid wash rig, and just maybe going over their skin. diffuse evaporation to help cool them down. We don't want to induce shivering though, because if they start shivering, the body's producing heat again. If they are seizing, we are going to use, our first line is Versed. And the reason for that is because it can be given via the MAD device. We don't want you guys going at these patients who are jerking and flopping around on the floor with a needle. That just puts you guys at risk for a possible exposure. So use your Versed first. Family members who, these kids may have some type of seizure disorder. What are they giving them? Are they giving Valium? They may be administering rectal Valium at home. Is something like Valium going to be better and help break the seizures? Remember that Valium and Versed stop the current seizure from continuing. It does not prevent future seizures from happening. All right? So if you go ahead and you have a patient and you're giving them the 2 milligrams of Versed and you put 1 milligram up one nair and the patient stops seizing, you don't have to finish off the second nair. They've stopped seizing. Okay? The only thing is you're going to snow them worse than they already are, and you'll keep them in that post-ictal state a little bit longer. Other things that can cause seizures is head trauma, increased ICP, someone who has a stroke. How about someone who is coming off of alcohol or certain drugs or going through withdrawals? That may actually cause seizures also. Someone who has sepsis, has some type of infection. So what are we going to do for them? Well, we start off with our ABCs, our routine medical care. The main thing is, yes, we want to get the medications on board as soon as possible to stop the seizure. But if they're on the floor, move things around so that they're not hurting themselves. Maybe someone cradle their head so they're not banging it on the floor. You can use oxygen as blow-by. They're probably not going to hold it on their mouth. And if they start vomiting or they're spitting up, you want to make sure you can turn them to their sides so that they don't aspirate. We don't put bite blocks in their mouth anymore. We don't put anything in their mouth. And we give the Versed. Now, for the adult, it's 2 milligrams every 2 minutes to a max of 10. If our patient is not stopping the seizure activity after 10 milligrams, we can contact medical control for more Versed or even switch to Valium if necessary. Don't forget to get a blood glucose level from these patients and correct that if necessary, and then just monitor them. Remember, at the post-ictal stage, they can stay in a post-ictal stage for up to 30 minutes after a seizure. Okay? Where things get a little confusing is our pediatric seizures, because we decided to go ahead and, all the different drug dosages. But Versed is 0.1 milligrams per kilo. If they're under 5 years of age, they get a max of 6 milligrams. If they're greater than 6 years of age, they can have the adult dose, the max of 10 milligrams. Okay. So, that doesn't make a lot of sense, but yeah, we can continue on. Now, if we have to give glucose, remember the glucose too has changed. Under 1, it's the 12.54 mLs per kilo. If they are 1 to 8, it is 2 mLs per kilo of D25. And over 8 years of age, it is D50, and it's 1 ml per kilo. We're really giving the same number of grams of sugar, it's just the concentration is different. And that's just because it's not as hard to push in, or it's not as difficult on the little vessels. Okay. But note that your main dosages here for your Versed, your maxes do change. Our febrile seizures talks about cooling the patient, but don't cause shivering. You do induce shivering, stop the cooling process. It says consider placing moistened towels in tepid room temperature water over the patient with a fan. But again, make sure you don't induce that shiver. Don't put them in a nice bath, and don't give them anything by mouth. So our Versed drug, I was going to tell you something. Oh, one thing I want to talk to you about is the capnography. Make sure you're using capnography with the seizures. The capnography can identify different respiratory patterns, or can sometimes identify that the patient is still seizing based on the waveform or the end tidal itself. And I know it's not in the protocol. I do recall Adam talking about calling medical control if your end tidal is still off, and even though they're not actively outwardly seizing, administering Versed if they're still having some type of seizure in the brain to get it to stop. But that's something that you'd have to call medical control about. But make sure you're using your end tidal for these patients. All right, so Versed, it's a benzo, okay? It can be used for sedation. It can be used as an anticonvulsant. Doesn't have any analgesic effect though. We use it for a lot of different things. We use it for cardioversion, seizures, behavioral. I think that's pretty much it. That's our main ones. It can cause drowsiness, and our drug-assisted intubation. Confusion, amnesia, but also watch for signs and symptoms of respiratory depression. Can also cause a patient to become hypotensive. So you want to make sure that you're really monitoring your patient closely. For the post-intubation sedation, we use it a max of 20 milligrams. Everything else is a max of 10 milligrams for seizures, cardioversion, or behavioral emergencies. Okay? Pediatric has their whole different set. Valium is another benzo that can be given. We use this for patients who are pacing, shivering, and it's also in our behavioral protocol. Dosages are a little bit different. Pacing, we give it 2 milligrams, but shivering and behavioral, we can have a max of 5 milligrams. We give it every 2 minutes, and we give a max of 10 milligrams for these patients. Watch for signs and symptoms of respiratory depression with this also. You might, again, why isn't this patient waking up? Why are they still like in that post-ictal state? Well, you might have given them a little bit too much Valium or Versed. So in the post-ictal state, as long as they're not going into that sleep, they might be combative when they start to come out. They don't understand. They have some confusion, but it can last up to 30 minutes. So with our drug-assisted intubation protocol, we use this for anybody who can't maintain their own airway. Less than 8, intubate. Someone we suspect has burned airway, or anaphylaxis are good indications. Someone with head trauma, someone we want to make sure we're protecting that airway. Your strokes with the neurological impacts, get them intubated early on. Just remember, patients who are over 60 years of age, we want to contact medical control to maybe see about drug dosages, just because, remember, elderly patients aren't able to metabolize some of these medications. We may need something at a little lower of a dose. So we'll start off having our partner oxygenate for about 3 minutes while we get things all ready. We're going to give etomidate as our main medication. Again, when you're getting ready to use it, we have people a lot of times that wait too long to attempt intubation when they're using the etomidate. Have everything ready to go. Have your partner go ahead and push the etomidate, 0.3 milligrams per kilo to a max of 20 milligrams. Once they've done it, count to 10, 15, and then attempt your intubation. Once the intubation is complete, you verify 2 placements. You have your end tidal in place. Remember, end tidal now is the first line method to determine if the tube is placed correctly. Once that's done, don't wait for the patient to wake up. Go ahead and give your 2 milligrams of Versed. Keep the patient out if you've got them intubated. So for post-intubation sedation, 2 milligrams every 2 minutes. And here we can go to a max of 20 milligrams. Don't forget applying a seat collar for them if necessary. Helps hold the head a little bit more stable so you don't lose the tube. Also, don't automatically think you have to use the ET tube. You haven't intubated in a long time, or your skill level is down, and you need an airway for this patient. Don't feel bad about grabbing that kin tube first, if necessary. If you go ahead and you take a look at the Mayo and Potty score and it's a difficult airway, and you know that your skill level is not up to par, or it's just a difficult airway, you can grab the alternative. Grab your king. Because no airway, no patient. The longer you take thinking around with the airway and not getting it, the more likely the patient's brain can become anoxic. So the main goal is to get them oxygen. All right, anybody have any questions? Yes, sir. Or yes, ma'am, I'm sorry.
We've recently come across pseudo seizures. They were talking about based on like some psychological trauma. Would you treat those much the same?
Can you tell that they're a pseudo seizure?
They don't present really much different. I mean,
That's right.
Yeah. So I mean, sometimes they'll tell you it's a pseudo seizure, but I mean,
The patient will?
no, the family member.
Oh, the family will. Yeah. Yeah. You know, I'm sure go ahead and use your Versed. But yeah, they can have the pseudo seizures, unless you're familiar with them and you know, then yeah, absolutely. Yeah.
Roll.
So this is the last. This is the last CE for the summer. I will not be back until September. I know, you're all so disappointed. Okay? Mr. Bannock, you can take this quiz too.
It's extra credit.
Excuse me?
Region 10.
Do you have anybody that's gone right now?
Yes.
Oh, yeah, there's two.
Yeah, so you can keep those then if you want to.
Thirteen-year-old, uncontrollable respiration. You can't control any of these. Well, let's go. Hard to deal.
That's what that sounds like. Yeah, you control diabetes.
Diabetes.
How do you control previous stroke? I don't know.
That might be pretty stroke.
I'll just control the line.
Well, sweet.
Well, I was right, it was good.
Saw like one sharp like red line just go down.
Which of the following signs and symptoms?
Excuse me, people are taking steps. to eat, to
This is hard.